Okay, I'm going to get us started here. Once again, thank you to everybody who has logged on for this evening's California Thoracic Society educational webinar. This is part of our every other Friday night educational webinar series. Tonight, we are thrilled to present Dr. Anzueto. The topic of his presentation will be nebulization in viral pandemics, evidence-based review. Before I introduce Dr. Anzueto a little further, I wanted to repeat a few things that I mentioned to the early participants who logged on. Tonight, we have a little bit of an extra engagement activity during our webinar in that Dr. Anzueto has included 6 different polling questions that will come up throughout his presentation. You will see these polling questions show up on your screen or your Zoom interface, whether you're on a phone or computer, and it's very easy to choose your answer. We'll leave each question up for 20 to 30 seconds, and we really would appreciate your participation. These polls and these questions are really as much for you as anyone else in this presentation, so you can see and understand how other medical organizations and professionals are handling different aspects of the information that will be shared during this presentation. In addition to the polling questions that will take place in the presentation, we also plan to offer our live question and answer session with Dr. Anzueto at the end of the presentation. Please use the Q&A function, the little icon with the letters Q&A and the little speech bubbles at the end of the presentation if you'd like to ask a question. Without further ado, I would love to introduce our speaker, Dr. Anzueto. He is the professor of pulmonary and critical care in the Department of Medicine at the University of Texas and chief in the pulmonary section of the Audie L. Murphy Memorial Veterans Hospital Division of the South Texas Veterans Healthcare System in the United States. He is a fellow of ERS and the American Thoracic Society. He currently serves on the editorial board of the American Journal of Respiratory and Critical Care Medicine, the American College of Chest Physicians Journal, the COPD Journal, and the Respiratory Research Journal. He has published more than 300 manuscripts in highly rated medical journals and has received multiple awards, including Teacher of the Year, Outstanding Pulmonary Doctor, and most recently, ERS Congress Chair Award 2021. This educational webinar series tonight is brought to you and presented by the California Thoracic Society in collaboration with Theravance Biopharma. Thank you so much, Dr. Anzueto. I'm going to turn it over to you.
Well, good afternoon. Thank you for the introduction. I want to thank the California Thoracic Society and all of you to spend these minutes on a Friday afternoon discussing what I believe is a very important topic. And it has to do is how do we treat our patients during this viral pandemic? And basically, I'm discussing in a few minutes what could be the objective. This webinar is sponsored for Theravance Biopharma. The scientific and medical understandings on the SARS-2 and COVID is continued to evolve. So this is information present on the data from the CDC, the World Health Organization, and this information may change in the future. I'm being compensated by Theravance to be part of this presentation, and in my conflict of interest, I also work with all the companies who make bronchodilators and antibiotics. And I have an intellectual conflict because I'm a member of the global initiative, the Gold COPD initiative for the management of COPD. I'm a member of the scientific committee, and a lot of the current recommendations for management, especially in asthma and COPD, has been adopted from this organization. So what I want to do today is let's understand what is the transmission mechanisms for viral pathogens. How can our patient get this virus? What will be the easiest way or the hard way to get the virus? Then we need to look at compare procedures considered aerosol generating base And this is on the recommendation for the different health authorities. We're going to examine available coronavirus data related to nebulization, and we're going to review the current recommendations to administering nebulized medications during the COVID-19 pandemic. So before we get started, I really want to understand, what are you doing? So we discussed we're going to have some polling questions, and this is our first question. What was your institution practice for delivering bronchodilators prior to the COVID-19 pandemic? And let's choose one item, please. The handheld devices only, so no nebulized therapy were utilized. Nebulized therapy only, nebulized only protocol, mix of both handhelds and nebulized therapy, or other. Now, I think it's important to understand what was your practice before the pandemic, and then we're gonna discuss and address what you're doing now, and then what should you do in the future based on the information that we have today. So please go ahead and answer, fill it up. These questions, please, one single choice of each of one. And we're gonna hold for a few seconds to be sure we get everybody's response. So here is the results. So most of you, around 75%, 74, sorry, use a mix of both handhelds and nebulized therapy. Very few use either one of those, and others use other devices. So let's go ahead and look into what are the issues related to this situation. So first, let's address viral transmission of respiratory pathogens. Now, on the left side on your slide is an infected individual, all the symptomatology. He or she can favor the viral transmission to two different pathways. One is to droplet nuclei transmission. This is aerosolized transmission. This is the particles are very small, less than 5 micrograms of diameter. And this tends to travel a little further out, 2 to 3 feet distance. And so that's the aerosol transmission. In the other hand, as you can appreciate in the bottom, is the droplet transmission. These are larger particles of more than 5 micrograms. But when you have larger particles, there is less distance that they can travel. So this droplet can be direct or can be direct through contact like hands, or indirect through contact to the areas that were contaminated. And all these will impact the susceptible individual. Now, there has been several in vitro studies that have look at the aerosolization as potential transmission pathway for transmission of the SARS-CoV-2 or the COVID-19 coronavirus. In the first study described on your left, Dr. Van Dollerman, this is in vitro experimental study. They use aerosol generated by 3-jet collision nebulizer that will generate a lot of very small particles, and they can demonstrate that the virus can remain active, viable in aerosolized up to 3 hours. And this is similar half-life that they have seen with the SARS-1 and the SARS-2, the prior SARS virus that had been identified. The investigators, Santarpia, they use air and surface samples collected in 100 isolation rooms where 30 mostly mildly symptomatic patients were monitored. They were using appropriate PPE and airborne precautions. 65% of the air samples in the room and 60% of the hallways turned out to be positive for viral RNA in low concentrations, and viral replication was detected in 2 samples in culture. So the highest concentrations in patients' room during nasal cannula therapy in the absence of cough. Similar, the study of the right side also used air samples, but this was done in one isolation room with 2 patients, one of whom was symptomatic. Again, the room had efficiency filtration, ultraviolet radiation, and 60% of the samples had positive RNA at a distance of more than 6 feet. And all positive samples demonstrated a viable virus in cell culture. So what's the message for these exams? Is it possible that the virus can stay? And especially if there is a very high concentration in the virus. So that's what makes it very important that we use all the procedures for precaution. So let's address what are these aerosol generating procedures. So the definition that is being given by the different organizations, and this is the definition that the CDC has used, is any medical procedure performed on a patient that can induce production of aerosols and droplet nuclei. This is more likely generate higher concentration of infectious respiratory aerosols than coughing, sneezing, talking, breathing, singing. All those have been demonstrated that an individual can have. But those procedures can generate this and present risk for opportunistic airborne transmission of the pathogens. This can potentially place the healthcare personnel at increased risk of pathogen exposure. But the problem is we don't have enough studies, we don't have enough data. I'm going to give you, what the literature can tell us today. Where are we and what are those procedures? This is data that was actually put together in early 2021 by the CDC and the World Health Organization, pretty much listing everything from upper suction, sputum induction, CPR, bronchoscopy, nebulized, manual ventilation. All those can potentially generate. Both organizations, the administration of nebulized treatment, they're calling uncertain because neither there, the CDC or the WHO advise against your nebulized treatment because there is not enough there. What we know is infection control, PPE recommendations during these procedures should include an N95 or higher level respirator, eye protection, gowns, gloves, and ideally a negative flow room. Now, then we can go and see across the board all the different respiratory societies and organizations, and you can appreciate from the NIH to the Society of Critical Care, there is a wide variety of discussion. But I think the important point is shown at the bottom. We all agree that the healthcare provider should have maximum protection to decrease the risk of contamination. So when N95 or higher level respirators, have face piece respirators, there should be limited the number of individuals who are present during these procedures. Ideally, it should be a negative flow room, and we need to clean and disinfect the procedure room surface promptly in order to decrease the risk of contamination for large particles. I know that today, probably most of your institutions already have policies established how to handle this. So we talk about how the transmission occurs. We talk about the procedures that can induce transmission. What do we know about in vitro and some studies of the novel coronavirus or the COVID-19? So let's go ahead and look at the evidence that look at the transmission, looking at the different procedures and the risk of these processes. Now, this is a systematic review of nosocomial transmission to healthcare workers taking caring of patients undergoing aerosol-generated procedures. And I think the important areas to highlight is the increased risk occurs with ambulatory ventilation, non-invasive ventilation, suctioning before intubation. If your patient is not paralyzed, very likely it's going to be coughing and can aerosolize, tracheostomy and tracheal intubation if the patient is not paralyzed. In our institution, we do rapid sequence sedation, paralytics. Our patients don't cough, the patients are well sedated. When the endotracheal tube gets placed, immediately it gets connected to the ventilator circuit after we verify that we are in the right place. So all that will significantly decrease the risk of the aerosolization. I also want to highlight what is shown at the top of this slide, some the procedures that has clearly been shown that are not associated with increased SARS-CoV-1 transmission. And these are the high flow oxygen, chest physical therapy, nebulized treatment. None of this has been associated. So, and these are today a pivotal therapies for the management of our COVID patients. High flow oxygen therapy, the use of nebulized medications and mainstay therapy in the management of our patients. We have, for example, a randomized controlled trial which showed that a nebulized inhaled corticosteroid can significantly decrease the progression in hospitalized patients with COVID-19 and will decrease the likelihood these patients will require further escalation and the need of endotracheal intubation. Patients with chronic lung diseases like COPD, asthma, nebulized therapy in these conditions will be the ideal therapy to deliver their medications, because it makes it very difficult for the patients to be doing any kind of maneuvers to get HFAs inhalers. So if we look at some of the studies that highlight the risk of development or transmission of COVID-19 to healthcare personnel during exposure to hospitalized patients, this is data from a study that was conducted early in the course of the pandemic that we didn't understand exactly what was going on. And in the left side of your slide, you can see all kinds of activities. You can see a group of patients with COVID and non-COVID-19, what can increase the risk, and certainly even doing a physical exam increases the risk. But if you can see that nebulized therapies, they were not increased in risk compared with the non-COVID patients. This was before we recognized the pandemic and we were implementing full PPE precautions. Once you include full PPE precautions, this study that was done in China, where nebulized treatments were used frequently, and you can see the cumulative frequency of the procedures done by different healthcare providers. Physicians were in the left side of your slide, nurses on the right side of your slide. You can clearly appreciate there that even that they increased the number of the frequency of procedures, the risk to develop infections were significantly decreased if they use full PPEs. And this is we're doing IgE and IgM antibodies and nasal swabs, PCRs plus deployment to try to evaluate and show there is not a very significant risk if you are fully protected. This was further studied in a systematic review by Chen and investigators that was recently published in March in Journal of Critical Care that showed the likelihood, and this systematic review has several studies, but the study that has most of the patients with nebulized therapy is the study by Liu and investigators that reported that with nebulized therapy with full PPE given to patients, the healthcare provider had very low risk of contamination. Now, certainly the COVID-19 has been looked at it and been a more interest because there is a potential increased risk of nebulization during the pandemic and in the patient who is very sick. That's why we continue to see studies and systematic reviews, but they are concluding that nebulized therapy is safe to be given. And remember, this is in the context that you're giving these therapies, you've been fully protected, because that is, at the end of the day, the most important issue. And so there's study by Dr. Complas wearing the N95 mask at all times when the procedures were done. That's what reduces significant your risk. Surgical masks are not a protection, and you should have eye protection as well as to help to have all the PPE during the nebulization. So nebulizing the vaporized virus starts a new Australia outbreak, and this happened because they were not having the full protection that the individuals who were giving these therapies. Now, if we want to specifically look at risk of transmission to healthcare workers, we have now 3 large epidemiological studies that has tried to address these issues. The study to your left by Boncini is a cross-sectional in the large critical care department in the London Teaching Hospital. They use staff questionnaires, antibody testing over a 3-day period. They had 625 participants. They detected antibody in 21%. And those working in diagnostic as higher seroprevalence, nurses, senior physicians, and respiratory therapists. So the 31% seroprevalence in staff with symptomatic household contacts and 60% in those with no household contact. So what's the message here? The message is, yes, it could be a risk from their occupational exposure, but also what we are seeing and we're seeing in our institution, most of the risk of infection our healthcare providers does not occur in the institution. They occur outside the institution. Their contacts and the people they are interacting with, that's what increases the risk to get infected. In the study by Lens, that is the one in the middle in your slide, this is a case control that utilized a large international online survey. They want to characterize association between exposures within and outside medical workplace. So they responded were over 1,000 healthcare workers in 67 countries, 244 cases with lab confirmed SARS. And the healthcare infection associated with non-AG contact with COVID patients and extra occupational exposure. So the lower odds of infection were associated with respiratory use, exposure to ICU care, and dedicated COVID units with negative pressures. Bottom line again, the facilities are taking all the precautions, and I can tell you, my institution, we take and we emphasize the need to have all the precautions. During the first waves, we have what we call closed ICU units. So you dress one time, we had these buffers, and you got all the area was red. So everybody, all the patients were infected. In the latest outbreak, we decided to go to a model of open units so the patients stay in the rooms, and we were wearing the precautions to enter. Either one, has shown to be very safe. The last study that was published in the IDSA a couple of months ago is, again, it's a retrospective case series from the upper Midwest. This is a cluster of 95 healthcare workers and 130 possible patient contact sequences. And 58% of the healthcare workers could not be linked to a patient, The 10% was traced to coworkers and 4% was traced to a patient source. I emphasize all these studies are showing us that our risk as a healthcare providers is low. Now, I think we have understood under the last year and a half that this novel coronavirus, this COVID-19, they tend to enter the airway, affect the airway, and the airway will have a very significant source for the virus to enter the body and eventually become systemic and give you a systemic disease. So there is a huge interest by many organizations to develop aerosolized medications for COVID. There are 7 nebulized COVID treatments on the developed in the US and the UK. There is a remdesivir preparation, nebulized remdesivir. There are nebulized interferon being developed, nitric oxide, prostacyclines that are being evaluated with the COVID ARDS patient population. The bottom line, what we are understanding is that, yeah, we can give all these systemic medications. We're giving dexamethasone, we're giving IV remdesivir, but what are they doing to that virus that is sitting within the airway and that producing tremendous amount of inflammation that is coming from the airway? So that's why there has been generated all this interest to go to the local source to manage this condition. So let me pause for a minute and let me understand and hear what is your current institution practice for delivering bronchodilators during the COVID-19 pandemic. So the question is very similar to the prior one, prior to the pandemic. So handhelds only, no nebulized therapy are used. Handhelds in COVID-19 only, nebulized for non-COVID-19 patients. Handhelds in all patients, nebulizing in some non-COVID and or ventilated patients. Nebulized products regardless of the COVID status of other. Now, I think this is very important. And I will expect to see a wide variety of what your institutions is doing, because this has been a process that is evolving. I'm going to wait to hear the answer to tell you what we have done in our institution. But in most institutions that I work and when I speak to people around the city of San Antonio and around the country and all around the world, there has been an evolving process of how should we address this issue, that what should be the appropriate delivery system from bronchodilators during the COVID pandemic. So I'm going to wait a few more seconds to see if we can get all your answers. We should be hearing from you pretty soon. Well, as I expected, I will expect this wide range of variety. So most of you, 40%, is handhelds in COVID patients only and nebulized for non-COVID. 21% handhelds in all and nebulized in some non-COVID. 23% nebulized product regardless of the COVID status. Very few handhelds other. I can tell you that when we started with the pandemic back in March, April 2020, we said, no, we cannot use nebulized. This is going to be bad. People are going to be infected. Our respiratory therapists, we're all going to go across the board. Everybody is going to be handheld therapy. Then we start finding out that our patients, that were not getting their medications. And more important, patients with underlying lung conditions and have like COPD, asthma, they're getting worse. Their condition was deteriorated. They're having requirement rescue medications. They're not getting their maintenance therapy. And we eventually, by August of last year, we have moved to nebulized products regardless of the COVID status. But I think one of the important issues is emphasize that not all the nebulized therapies are the same. The current treatment recommendations for patients with chronic lung disease, let's say, for example, COPD, is not to give duoneb every 4 hours or 6 hours, even if they are in the hospital. The treatment is use the long-acting bronchodilators. We have now LAMAs, LAVAs, ICS that can be given nebulized once or twice a day, and use the rescue inhalers, those duonebs, albuterols, ipratropions, as a rescue only. And I think this is what we need to emphasize, that we need to give appropriate therapy in our patients at all times. So let's address a couple other issues and some of the considerations for nebulized therapy that in the COVID-19. There are very important terminologies. So we know about the bioaerosols, so generating by patients when you cough, laugh, sing, you would produce. There is a medical aerosol that can be produced by the drug delivery devices. But there is another important issue that we should take into consideration. That is the fugitive emissions. So these are the medical aerosols released from aerosols device during the patient exhalation. So this is not intended to happen. The medication is intended to be given and stay on the patient's lungs, but during his or her exhalation, these fugitive emissions do occur. So let's address how you should handle some of that. Have you ever recommended a filter for use in your practice? For example, yes, with the spirometry, the PFTs. Yes, for use in COVID positive patients or patients undergoing for COVID-19, like the PUI, patient investigator. You are not sure, no, you don't use it. Oh yes, we use it in both with spirometry and in patients who have COVID. So most of these filters, as filters are placed in the expiratory port, there have been delivery systems being developed to try to minimize how much aerosolization do occur. So let's see what you are using, or when do you recommend the filter in your practice? Here we go. So yes, for using COVID positive patients or patients on the PUIs, that's what most of you, and the second, most of you will use both for PFTs and in patients with positive COVID. So bottom line, the message you are telling me is we're trying to protect these fugitive emissions to reduce the risk of the contamination. Now, there are been a series of in vitro studies to try to address these issues. They use different filters here. This study, they use the Parry filter, filter that has been shown is comparable to the N95 particle respiratory mask can trap up to 95% of particles. And if you can see in the study, there is how much quantity of expiratory release occurred during the nebulization in this in vitro study. And the area of the top is in face mask with no filters. Once you go towards the bottom and then you have less emission, is when these Parry filters are being used to help to trap these emissions. Now, we have many different delivery systems. We have standard jet nebulizers that you can see here on your left, the mesh nebulizers that are a little more, more sophisticated particle size, the HFA delivery devices, the dry powder inhalers, the soft mist inhalers, and all these have been, how can we deliver the respiratory medications today? Now, one of the important issues is that cough and cough that is induced by the patient getting the medication, this is one of the areas that has been shown that increase the risk. Sorry. Increase the risk of having the nebulization. So we know now we have data of the risk of the incidence of cough, and the cough is more likely to be produced by HFA delivery systems. There are studies done with some of these DPIs, some of the inhalation solutions, as well as some of these other deliveries. So that will be the bioaerosolized production that can occur. This is a guidelines for different respiratory societies, and there are comments that pretty much emphasizes, one, the point that we need to give appropriate therapy to our patients, and certainly that we could use a nebulized delivery system. So as a practical recommendations to use nebulized therapies, certainly the less amount of treatment the patient receives, the less likely is to get a contamination. So the reduction in frequency is going to be a pivotal, giving once or twice a day medication instead of every 4 to 6 hours. There is no need to give every 4 to 6 hours. It's probably important to use filters with nebulizers. Consider using mouthpiece nebulizer to prevent the fugitive emissions with a face mask. In some areas, they apply a surgical mask on top, like the high flow nasal cannula, using a negative pressure room, but more important, your staff, they have to have the appropriate protective equipment, and remind your staff that after the patient received their treatment, the nebulized therapies, to wash their hands, to try to decrease as much as possible the risk of large particle contamination. So let's have another question. Do your institution have any inpatient initiative implemented by your department to reduce the frequency of bedside care for COVID-19 patients? This is a simple yes or not. So what kind of initiatives you have putting in place in order to reduce the frequency to enter the room and potentially your staff being exposed? During the first waves of the pandemic, one of the other issues, we were having tremendous limitations on the protective equipment, the PPEs. Now, these new waves, we seem to be better prepared, and that's not an important issue. So let's go ahead and take a look at your answers. So it's almost 50-50. Most of you have developed initiatives, but it's still close to 36% don't have any significant initiatives. That's okay, because one of the major challenges that we all have is, and the dilemma that we all confronted every day, is how can we provide our COVID positive patients the highest level of care as a non-COVID positive patient? And if that implies to do any interventions, we try to do it, and we try to maintain that. So let's go here. Now, so we have studies that have looked at the amount of PPE that it can be reduced in hospitals based on how the treatments are given. And for example, the left side in your slide is COVID-19 PPEs will contribute close to $320 billion to us hospital losses in 2020, and probably $122 billion in 2021. And what it lists over there, the list is in non-ICU and ICU changes patient day. So how much PPE needs to be used. And as you can anticipate, in patients who have in the ICU, You're going to be using more gloves, you're going to be using more masks, and probably as many gowns that the other patients. So that brings to the right side of your slide the importance to how often like nebulization therapy is given. What is the cost of doing that? And in the left side of the graph in green, we'll show you the therapies with albuterol and ipratropium that are given every 4 to 6 hours. So there's a tremendous cost to your system. While on the right side, new interventions like a once a day long-acting anticholinergics or twice a day LAVAs or ICS can significantly decrease the cost of your personnel given the therapy, as well as the cost related with the PPEs that has to be worn. Because today in August 2021, after almost 16 months of this pandemic, we don't have any question that our staff must wear full PPE to protect themselves when enter the patient's rooms. And this therapy is, well, of course. So let's understand a little bit more how are COVID-19 or rural COVID-19 patients currently being nebulized in your institution. I believe it's a single choice, please. Like a standard jet nebulizer plus or minus a filter, breath-actuated nebulizer plus or minus a fixed filter, the vibrating mesh nebulizer, the variable depending upon patient location, uninsured, or nebulizer not used in COVID-19 patients. So this is pretty much listing you all the different alternatives or nebulizers that we have available, from the newest one, from the vibrating mesh nebulizers to the standard jet nebulizer that has been part of our standard of care for the last 20, 30 years for the treatment of these patients. So let's take a look at your answers. And if you can see, most of you are not sure what do you have, will vary between the location. A small group of you using the vibrating mesh, of some are standard nebulized. But let's look into that and address some of those issues. So the message is that we need to give the patients the right route to give the medications. You can have the best medications in the world, but if the patient cannot get it, it's not going to work. It had been recognized that the people who benefit from nebulized therapy are those individuals who have poor lung function, they have more severe lung disease, they have lowest their FEV1s, their respiratory muscles are weakened, their maximum inspiratory pressures are significantly reduced. We all use the standard in patients with cognitive impairment. And I will make the point that some of our patients who have severe hypoxemia associated with the COVID-19 infection, they're not able to maintain very well. Certain manual dexterity is a challenge in persons with arthritis, neurological conditions, poor hand grip strength. That will be very hard to use handheld devices or HFAs. Other inability, like they're not able to hold their breath or be able to do all the steps associated when you need to get any of those devices like HFA. So these are clearly indications that is recommended today that when we need to use these devices. We do have knowledge gaps that are very important to highlight. There are very limited clinical studies that you saw in COVID-19. There is lack of information on viral transmission risk with nebulization itself, because you have to take into consideration that it's not only that the particle and the amount of the particles have to do with the individual, has to do with the respiratory effort, how much of that virus are able to stay within the individual. Studies are needed for viral particles at different distance from the patients with these virals, handhelds versus nebulizers, different type of nebulizers. difference between the aerosol generating procedures and the types of PPE and precautions. I'm highlighting here that there's a significant gap in our understanding of what we should do. So let's have one last question for you all. And this is, what are your views on using nebulized medication during the COVID-19 pandemic? One is avoiding all the patients regardless of COVID status. Two is only use in non-COVID patients. And three is continue to use in appropriate patients with recommended precautions, PPEs, negative flows, N95, etc. So I hope I have made the point that there is some patients that don't need these medications. What will be, how we want to be using them? Let's take a look at what are your opinions on this. So most of you will continue to use inappropriate patients with recommended. And I think that is probably the message of my presentation, is that we are not giving these medications by choice. We're giving these medications by needs. What our patients need? That's what we have to do. Our goal has to be to fulfill their needs in their medications. So what I want you to take home is that certainly the coronavirus came and has had a tremendous change in our life. When we we are in control, it throws another curve in us. So it is a continuous learning process that we are experiencing. And please be vigilant, please be careful, protect yourself. Probably most of you are vaccinated, we still can be infected. We're all gonna have to get a booster or a third dose, however you wanna call it, in the near future. But at the end of the day, after you protect your staff and yourself, our patients must receive an appropriate therapy for the underlying lung conditions. And nebulized is an alternative for a lot of patients who require hospitalization. And many of them, when they go home, allows to bridge them and to continue with appropriate care. I'm going to stop now. I'm going to be happy to answer your questions. I have here different comments. One in the chat that says that my facility cannot afford handheld treatment, and certainly that it can be a tremendous challenge. And this could be in part due to the fact that we are having a tremendous strain in our healthcare system, in our staff. The first wave, we'll say we're gonna make it. This is bad, but we're gonna survive. The second wave, we say, well, gosh, this is tough, we're gonna make it. The third wave is really, really having an impact on everybody. And we don't know how many more waves are on our way. So my advice and the advice that I give to my team is, this is not a marathon. This is not a race. This is a relay race. People have to rest while people work. Other people rest, other people work. That's the only way we're going to be able to overcome this. I know we all want to do the best. I know we all want to try to do, but you have to be very sensitive to emphasize that your staff, they have to take day off. They have to use their vacation time. And I know it's tough when you're a little short-handed. All people have to bear the weight. But if we don't divide that, we won't be able to survive, because we don't know how many waves may be coming down the road. We thought it was one, we're going by 3, 4 in some places. So it's just going to be a matter to sit and wait. There is an important question from one of the attendees. What is your opinion on the use of IPV for COVID patients? I imagine by IPV is a positive pressure ventilation and COVID patients, and also all these maneuvers to help to to help to increase secretion management. My advice is you have to do what you have to do. A lot of those patients, they do develop very thick secretions. But you may remember, like at the beginning of the pandemic, when New York was getting hit with a tremendous amount of cases, they were reporting they had tremendous amount of mucus plugs on patients on the ventilator. And you know why they had the mucus plugs? Because they were afraid to have a humidifier systems attached in the ventilators to humidify for the potential that that can aerosolize the virus. At that time, we didn't know that once you have a closed circuit with the ventilator, the risk of aerosolization was very low. Your ventilator has an expiratory filter so that fugitive secretions were really very low. And once we start going back to our standard of care, that is the use of humidification, that problem got solved. We didn't have more mucus plugs in our patients. So what's the take-home message? Take-home message is over the last 20 years, we have developed a standard of care for our patients who are critically ill, that are on the ventilator or they are in a hospital with severe hypoxemia. We should do that standard of care today. We should not change that standard of care because it's COVID-19. The change that we're doing is we emphasize how our staff can cover the using the PPEs, but the patient should receive their standard of care. There is a question about how will uncooperative patients be taken into consideration in these cases? There are times where patients are inconsiderate, whether it's intentional or not, that cough in any direction. Yes, yeah, that certainly is a concern. With nebulized therapies, you should be able to contain some of the spaces, and some of those patients, what you want to do is have them and put on them a surgical mask to try to trap as much of possible of the secretions. Having said that, it goes back to the point I was making before. You protect yourself. You maintain a distance. If an individual cough, you are more than 3 feet, the likelihood for you to have any of these particles are going to be very low. Before you leave that room, you wash your hands, and when you get out of the room, you remove your PPE. And with that, you won't have any problems. Would you then recommend using the bed CPT during mechanical ventilation? Yes, I would recommend use the bed CPT. I would recommend to have any measurements, including continuous rotation in the bed, anything that is needed to decrease basal atelectasis and increase aeration in the bases of the lungs. A lot of these patients are very severely ill. We are placing them in a prone position. And you are very aware of that. And so, you know, be very careful, you know, keep an eye. In my team, when we put a person in a prone position, there is one person responsible of the airway and the ET2. So that person will not do anything but put his or her hand on the ET2 and hold everything in place until the patient is in the right position. So to try to maintain the airway is critical to not to run into any problems. Any other issues, anything else that you would like to address? So we're getting close to the top of the hour. I want to thank you all because, I mean, it's a Friday afternoon. You are incredible, you know, to be here. And this is because you care about your patients and you have questions, concerns, what should we do? And I struggle with that. I struggle with that every day. I struggle with my patients. Am I making the right decisions or not? But don't try to do what you have done. Don't believe all this other stuff that people say, oh no, if you do this, you will have more problems. Don't believe that. You do what is your standard of care. There's a question, what is your experience with giving NEB treatment to patients on high flow nasal cannula? Can nebulized medication be delivered when patient is on 50, 60 liters? Yes. So when patients are with high flow oxygen with the nasal cannula, what we do is we continue the nasal cannulas in place, we place a face mask, and we give them the nebulized bronchodilators on top of that. So you can give them the medications. Can IPV increase chances of pneumomediastinum? So barotrauma has been recognized we've been seeing more and more reports in the COVID pandemic that we have seen before. I had the opportunity to do a data analysis in a large database. You know what's happening? The reason we are beginning to see more barotrauma is in part because we're not following our ventilator standard protocols. We're allowing high peak pressures. We are allowing tidal volumes of 8, 10 mL per kilo because we got patients with mucus plugs and atelectasis. And it goes back what I told you before. We have 20 years of extensive research in critical care and ill patients. We know what's the standard of care. That's what we need to apply to our COVID patients. The COVID patients is not the time to come and investigate something new. And your standard of care is to have the ventilator with a nebulizer, with the humidification to deliver air, with your filter in place. And don't worry, your stuff is not going to get contaminated. And we have seen studies, a really large study, like for example, high flow oxygen increases the risk of staph contamination. There are institution-based studies that demonstrate that it's not, that your staff is not being put at increased risk, wearing your PPEs and taking all the necessary precautions. Well, I want to thank you to all of you again. I want to thank the California Thoracic Society for the opportunity to be here with you all. And I want to thank our sponsors, Theravance Biopharma, to give this opportunity to discuss this very important issue. You all have a good night. See you later and be safe, please.
Thank you so much, Dr. Anzueto. Really appreciate your time. I think all of our participants really found it comforting, reassuring, absolutely informative, and just very timely. It's great to have this level of open communication, and we really appreciate your time and your views. Have a wonderful weekend yourself.
You too. Thank you very much. Thank you all.